Welcome again, friends. Let's move ahead with the part 3 of the guideline, the Ovarian Hyperstimulation Guidelines by ESHRE 2025. We will start our discussion today with monitoring. The monitoring during the ovarian stimulation cycles. There are various ways to monitor the cycles. One is the ultrasound monitoring, which is most commonly done. And another form is the hormonal monitoring. So we'll see what guidelines have to say regarding the monitoring. Moving ahead with hormonal assessment during ovarian stimulation. The addition of hormonal panel consisting of estradiol, progesterone, LH to ultrasound monitoring is not recommended. So only ultrasound monitoring is enough. While stimulation, no hormone needs to be measured to assess the success of the stimulation. Measurement of endometrial thickening. Routine monitoring is not needed. Only a single measurement of endometrium during ultrasound assessment on the day of trigger or pickup is enough to tell the patient about the chances of pregnancy success in case the fresh transfer is planned. Moving ahead with criteria for final oocyte maturation. So there are many criteria which have been proposed regarding the when to give the final trigger, like follicular size, estradiol levels. But what guideline has to say, let's check. So the criteria for final oocyte maturation based on follicular size. The association of follicular size as a triggering criteria with outcome has not been sufficiently studied. Physicians may choose the follicle size upon which the final oocyte maturation is triggered on a case-to-case basis. Why? Because the decision on timing of trigger has many factors which are involved, but mostly the final oocyte maturation across the clinics is based on the size of the leading follicles, which can vary from 16 to 22 mm. Anywhere in between this, the trigger can be decided. Previously, the second criteria used to be the estradiol levels also, but guideline development groups are not recommending the final oocyte maturation trigger based on estradiol levels alone. Hormonal assessment on the day of final oocyte maturation means on the day of trigger. So in cycles in which the HCG trigger has been planned, in those cycles the progesterone measurement on the day of final oocyte maturation should be done, because when we are planning for the fresh embryo transfer, anytime the progesterone level more than 1 nanogram per ml have been shown to be associated with lower pregnancy success rate. So that's why one single serum progesterone on the day of trigger is what is guideline also recommends. The decision to defer embryo transfer should include other factors also, like number of oocyte, number of embryos, and embryo quality. Estradiol measurement on the day of trigger is not recommended. LH levels on the day of trigger is not recommended. The gonadotropin releasing hormone agonist trigger cycles. It is not recommended to measure any of the hormones on the day of agonist trigger in freeze-all cycles, because anyways the fresh transfer is not recommended in the patients receiving the GnRH agonist trigger. So that's why there is no point of measuring the hormones too. Criteria for cycle cancellation. In case of lower oocyte yield, a low response to ovarian stimulation is not a reason to cancel the cycle. The criteria for cycle cancellation in patients having high oocyte yield in GnRH agonist cycles with ovarian response of more than or equal to 19 follicles more than 11 mm, more than or equal to 11 mm, there is an increased risk of OHSS, and at no cost we want patient to go into OHSS, because patient safety is always a topmost priority. So that's why in such conditions the cycle cancellation means the cancellation of the final oocyte maturation trigger is one of the options, because in GnRH agonist cycles the only possibility to trigger is the HCG, and HCG is known to cause OHSS in patients having exaggerated response. So that's why the cancellation of the cycle by withholding the trigger is also one of the methods to prevent OHSS. In GnRH antagonist cycles, withholding the GnRH agonist may be considered in women with extremely high ovarian response. Otherwise, in GnRH antagonist cycles, we are giving GnRH agonists as a triggering agent to prevent OHSS. But sometimes the ovarian response becomes extremely high. In those cases, we can think about the withholding the GnRH agonist. So thank you, friends. So in our next video, we will be discussing rest of the part of the guideline, which is very important, which will include the luteal phase support. So that part is very important. So see you in the next video. Thank you.